Thank you for joining us for our short course today. I think what we're going to try and do, if we can, to get everyone started, is to go around and have introductions, which is a lot easier when you're in a room together because I could just point people out. But people, as they appear on the screen, I can probably say the individual's name in the order that people are appearing on my screen and give you a chance to introduce yourself and just maybe say quickly what's brought you to this short course to look at equity. But to get us started, I can introduce myself, and Fan can introduce herself as well. And also I will apologize in advance if I mispronounce your names by reading out what is written here on Zoom in front of me. So I should be able to see most people. I'll just give a couple more minutes for a couple more people to join here. So Fan and I are in the UK, so it's 2 p.m. for us here. So it's the afternoon where we are. And a sunny afternoon actually at that. So that's nice. Okay, we've got a good number of people joining now. I've had a couple of emails from some participants who said they would not be able to join live, but these are being recorded as well. So I think you'll be able to watch these back in case you want to afterwards, in case that's helpful. So I'll start by introducing myself. I'm Susan Griffin. I'm a health economist at the Centre for Health Economics in the University of York in the UK. I work in economic evaluation. And so I've worked in that throughout my career, and I've got particular focus on quantifying health inequality impacts in economic evaluation. So I work across a range of different areas, a range of different disease areas, and I do a lot of work in public health, which links quite neatly with the health inequality focus. So that's me, and I'll pass over to Fan to introduce herself as well.
Yeah, hello everyone. My name is Fan Yang. I am a research fellow at the Center for Health Economics, University of York. And in the past 3 years, the main focus of my research is this inequality impact in economic evaluation. We would like to expand this analysis framework to inform public health decision making. So it's really a great opportunity for me and to work with Susan to present our work, to share our experience with everyone here. Thank you.
Okay, thank you, Fan. So if I call out your name, if you could please just give a quick introduction of yourself to everyone and a brief sentence about what brings you to today's course on equity. So Heather Gold, please, first.
Hi, I'm Heather Taffet Gold. I'm a professor at the New York University School of Medicine. I teach economic evaluation in healthcare for our master's program. And I've been trying to put more of a health equity, racial justice lens to my half of the class this year. So this fits in nicely. I'm not sure if I'll chance to teach it next week, but I may try. And I'm a health services researcher. I do a lot of different types of large database analysis, economic evaluation, especially in implementation science these days.
Okay, thank you, Heather. If we could go to Natasha Stout next.
Hi, I'm Natasha Stout. I'm in the Department of Population Medicine at Harvard Medical School in Boston, and I'm a simulation modeler primarily and do work in breast cancer screening and treatment, and increasingly sort of issues about equity are kind of coming up in our analyses, and so I'd like to be sort of better equipped to address them.
Okay. Thank you, Natasha. Lisa Prosser next, please.
Hi, good morning. I'm Lisa Prosser from the University of Michigan. My research focuses on measuring the value of children's health interventions. So I'm especially interested in thinking about these methods in the context of measuring children's health and for disadvantaged populations more broadly.
Okay, thank you. John Wong next, please.
Hi, I'm a primary care physician and chief of the Division of Clinical Decision Making here in Boston, where it's pretty cloudy. I have an interest in the notion of trying to quantify health equity. I'm also a member of the U.S. Preventive Services Task Force, and as you might guess, with the inequities in the response to the pandemic, quantifying such inequities for decision analyses is an important aspect of what we should be doing going forward. So thanks.
Okay, thank you. And Stacey next.
Hi, my name is Stacey Kowal. I'm a health economist of 15 years, focused mostly on economic modeling and decision aids, and a background in economic modeling work for BARDA. But I currently work for Genentech in the Health Policy and Systems Research Group. And we have a large focus on diversity, equity, and inclusion. So trying to figure out, ways in which we can connect HEOR and a little bit more inclusion or understanding of inequity within healthcare.
Okay, thank you. Cody Black next, please.
I'm Cody. So I'm a health economist at CADITH, which is Canada's HTA agency, for those who aren't familiar. So equity considerations have come up in a number of our deliberations over the last several years, and they keep popping up more frequently. And so just trying to get some, some base level information to start off with to become more equipped to deal with these types of considerations.
Okay. Emily Berger, please.
Hi, everybody. My name is Emily. I am an assistant professor here at the University of Oslo, but I also have a position as a research scientist at the Harvard Center for Health Decision Science. I'm also a simulation modeler and predominantly within cervical cancer screening. And I'd like to echo what a lot has been said here already about exposing both my own students to equity considerations when conducting a CEA, but then also considering possibly figuring out how to incorporate into my own analyses.
Okay, thank you. Caitlin Biddle.
Good morning, my name is Caitlin. I am a PhD student in health policy and management at the University of North Carolina at Chapel Hill. I'm studying decision sciences, and so we receive kind of, the standard cost effectiveness analysis training. And so I'm looking to expand that to my work in cancer care equity and really looking at financial toxicity in that space.
Okay, thank you. And now I apologize if I get this wrong. Ziyu Michaud.
Hi, my name is Ziyu Michaud. I'm a research faculty in the University of Nebraska Medical Center. My main work is I did lots of economic evaluation in the telemedicine, and also now it's more in the weight management program. And so this is the first time I hear this course, and so I have no idea. Oh, we can use take the health equity lens when we conduct the cost effectiveness analysis. I think it is really, I want to apply this perspective in the future, either my work or grant application, since I also affiliate with the Center for Reducing Health Disparity. Thank you.
Thank you. David Kim next, please.
Yep. Hello, I'm David Kim, assistant professor at Tufts University School of Medicine. My research interest is really developing simulation modelings to inform the policy decisions. I have developed few simulation modeling recently, micro simulation model for diabetes and cardiovascular disease, and we try to evaluate a lot of different policies, public health policies and food policies, and try to incorporate this distributional CA into our analysis. So I'm trying to, looking forward to learn more about it.
Okay, thank you. Sarah Stein, please.
Hello, everyone. I'm Sarah Stein. I'm a research programmer. I work with Natasha, who talked earlier. And my background is actually more on the sociological side of diversity, equity, and inclusion. So I'm very interested in this topic.
Okay. Julia Santamaria.
Hello, my name is Julia, and I'm a PhD student in the Institute of Public Health in the University of Umid, Tyrol in Austria. and the topic of my thesis is obesity prevention interventions, and I would like to incorporate the perspective of like all these equity issues into my decision analytic model for obesity.
Okay, thank you. Grace O'Brien.
Hi, I'm Grace O'Brien. I work as a data manager at Boston Children's Hospital, and we do a lot of simulation modeling. And just echoing what other people have said about modeling, I'm interested because we want to find a way to include and incorporate these inequalities in our modeling.
Thank you. And now I must doubly apologize because this name doesn't even show in full on my screen. So Adeteju, and then I'm afraid the surname is cut off for me.
Yeah. Hi, everyone. So my name is Adeteju, just like you rightly said. I'm a second-year PhD student in the health service research at the University of Toronto, with focuses on health technology assessment. I'm interested in this course because I'll be using this method, the equity-informed cost-effectiveness analysis, for my thesis project to assess the economic relief programs that are implemented during pandemics, and see who benefits and most from it and all that. So that's why I'm here.
And Manhwa Young next, please.
Hi, everyone. My name is Manhwa Young, and I am from the Public Health Agency of Canada. I'm here today because one major piece of our work is we are collaborating with external experts to develop Canadian guidelines for economic evaluations specific to vaccines. And so one topic that we're talking quite a bit about is on equity. So I'm here to learn.
Okay, thank you. Evan Jacobson, please.
Hi, everyone. I'm Evan Jacobson. I'm a simulation modeler at CDC in Atlanta, Georgia. And I do have some work in the health inequality field for HIV modeling. And so I'm curious to hear other opinions and some more suggestions about it.
Okay, Irina.
Good morning, good afternoon. My name is Irina Kolobova. I am on the policy evidence research team within the Center for Observational and Real World Evidence at Merck. And in my role, I support our product teams in thinking through what is the impact of social drivers on our value evidence, and really thinking through how it fits into the modeling.
Okay, thank you. And Oshima Sachin.
Hi, everybody. I am Oshima Sachin. I work with the Health Technology of Assessment of India Division of the Department of Health Research in the Ministry of Health and Family Welfare, India. And this is a newly formed division in India, a 3-year-old division, wherein we have started undertaking cost-effectiveness analysis of healthcare interventions and devices mainly to start with. And I worked on reproductive health cost-effectiveness analysis. In India, we look forward to incorporate equity in cost-effectiveness modelings. So happy to be here and learn more. Yeah, looking forward.
Okay.
Thank you.
Elena Elkin next, please.
Hi, my name is Elena Elkin. I'm a professor of health policy and management at the Mailman School of Public Health at Columbia University. I'm a cancer health services researcher, and I do cost effectiveness analysis these days, mostly in the context of randomized trials of interventions for cancer patients and survivors. I also teach decision analysis and cost effectiveness analysis to MPH students, and I'm eager to bring these methods and perspectives to my teaching.
Okay, thank you. And Christopher, I'm afraid the surname is cut off for me again.
Hi, everyone. My name's Chris Cadam. I'm a PhD student at the University of Michigan in the Health Services Organization and Policy program, specializing in decision science. My research interest is broadly in using modeling for cancer prevention and control policy, and I'm interested in understanding how we can incorporate equity into population level policy decision making.
Okay, and Lee Kyu-Yun.
Hello, my name is Q. I'm a postdoc fellow at the University of Pittsburgh. My research focuses on predicting trends in the burden of disease using mathematical model. And the goal for me this year at SMBM is to learn something new. And then I recently read media and articles on differential impacts of COVID-19 across race and ethnicity groups in the United States. So that would be a nice area to explore.
Okay, thank you. And Josh Carlson, please.
Hello, everyone. Josh Carlson. I'm Associate Professor at the University of Washington and the Choice Institute. I do a fair bit of cost effectiveness modeling. I run our team that does ICER evaluations and ICER reports. I've been interested in equity for a while, so I'm just looking to get a hands-on look at using this technique. I teach this as well in our school, so also interested in perhaps having a lecture or two on this topic. So glad to be here today. Nice to see everyone. Bye.
Okay. And Jin Tae.
Hi everyone, I'm Jin Tae. I'm an assistant professor at the University of Utah at the College of Nursing. My work is mainly in the hospice and palliative field, and yeah, I'm just interested to learn about health inequality. We're working with some population data sets and trying to learn more on how to model that.
Okay, thank you. Erica?
Hi, can you hear me?
Yes.
My name is Erica. I'm a student at Western University and Ivy Business School, studying a combination of epidemiology, statistics, and business. And so I'm in some introductory health economics courses right now, but I'm interested in doing future research in the area. So just trying to learn as much as I can. And the prof I'm currently working with suggested I attend this course, so looking forward to it.
Okay, great. Nancy Bolus?
Yeah. Hey everyone, my name is Nancy Bolus. I'm a postdoc in the Global Pediatric Medicine Department in St. Jude Children's Research Hospital in Memphis, Tennessee. And my work is focused on costing and cost effectiveness analysis. And since it's the global department, a lot of our work is directed towards low and middle income countries. So we still haven't tried to integrate inequity yet, but it's something I look forward to learning more about and integrating in future projects.
Okay, thank you. Michael next.
Good morning, this is Mike Grabner. I'm a principal scientist at HealthCore, which does health services research on behalf of Anthem, one of the largest US health insurers. My training is in economics, and I've done a few pharmacoeconomic studies. I attended an ISPO session from Dr. Griffin about equity in CEA earlier this year, and I was quite intrigued to learn a bit more about this. So excited about the class today, although I might have to skip in and out due to some other conflicting meetings. So apologies for that.
Okay. Samantha next, please.
Hi, I'm Samantha Verbrugge. I'm a health economics researcher at CADIF, which, as Cody said earlier, is the Canadian HTA agency. We do a lot of work behind healthcare decision in Canada, so I'm looking for more information on how to better consider and account for inequality and inequity in cost effectiveness and some of that decision making.
Okay, thank you. Madeline, please.
Hi, I'm Madeline. I am a researcher at Massachusetts General Hospital at the Institute for Technology Assessment, and I work on a team that does a lot of simulation modeling and cost effectiveness analyses, and so I'm here to kind of learn more to inform my work as part of that.
Okay, and Loretta, please.
Good morning, everyone. My name is Loretta Shea. I'm a postdoctoral research fellow at Kaiser Permanente Northern California in Oakland. It's 6 a.m. here, so pardon the video off. It'll come on when the sun comes up. Clinical psychologist by training, and my focus is on disparities in medical care and medical outcomes among immigrants and people of color, with a particular focus on the effects of discrimination, racism, xenophobia, etc., on behaviors, healthcare utilization, and physiological functioning. And I have little no experience with cost analysis, so this seemed like a good opportunity to soak up new knowledge, so I'm really looking forward.
Okay. Well, I think I got everyone, but do speak up if I haven't said your name, because there's quite a few participants. Okay, this looks good. So what we're going to do is we're going to run the session. While I'm presenting the first part, Fan can be monitoring the chat. So please do chip in with any questions that come up, and we can try and take them throughout, try and keep it a bit more interactive. So we've split it. You'll see the agenda once I start the slides. We're not going to stick necessarily rigidly to that, but at the end of each section, we're going to pause and see if we can, if there are some questions as well, and see if we can have a bit of a discussion. And there will be a coffee break. The coffee break is scheduled for around 10:45. So you know when that is, but we'll try and also, depending on where we are with the schedule, allow for some extra screen breaks, just 5 minutes in between different sessions as well. So you're not just sat in front of the computer for a number of hours. You should have all received the exercise slides, exercise materials via email, and we've also put them in the chat window for you to download as well. And I guess in terms of general housekeeping, if you want to keep your microphones on mute when you're not talking, that would be great, just in case of any background noise. So I'm going to try and share my screen now to begin the presentation. As I said, Fan will be looking at the chat window. I think I kind of lose sight of that whilst I'm talking. So if you do want to raise something, feel free to chip in or post it in the chat window, and we'll pause every now and then to review comments. So let me just get this shared. Okay, can everybody see that? Fan, can you see this? I'm going to take that as a yes, because nobody has said that they can't. Okay, so we've introduced ourselves, but there's a bit more of a biography of myself and Fan here. We both work at the Centre for Health Economics at the University of York. And this is the rough agenda that we've put in place. So we've had our arrival and welcome, and it sounds like a very interesting group of people that have joined us today, so that's great. I'm going to give a bit of an overview to start with about health inequalities or health disparities, and then we'll have a bit of a pause, a bit of discussion and a bit of pause. Then I'll look more at incorporating health inequality to inform resource allocation. And again, we'll have a bit of a discussion and a bit of a pause. Then I'm going to hand over to Fan, and she's going to walk through an example in smoking cessation, so you can see a bit more about how it works in practice. After that, we'll have the coffee break. And then when we come back from the coffee break, we're going to walk through the exercise slides together, because with this kind of Excel-based exercise, it's handy to do it live on your laptops if we're there in person, to walk around the room and help out. But I think walking through it on the screen might be the better option for this virtual environment. But you have the exercise files and the step-by-step instructions to be able to go away and do it yourself if you would like to. And then we've got another session at the end that we can use for question and answers. So we're here to talk about health inequality or health disparities. So this is something that's recognized to be a problem. So this is more than just differences in health between two individuals that are at random. So somebody might live a bit shorter life than others. This is more about systematic differences in healthy life expectancy between groups, which you can associate with their characteristics, with their individual characteristics. And often we talk about this in relation to socioeconomic disadvantage, different socioeconomic groups. It can be between people with different ethnicity, but sometimes people also relate this to characteristics of diseases as well, so severity of disease and things like that. But the main focus we're going to be talking about it in relation to is socioeconomic groups here. So when we talk about health inequalities, we're talking about the different aspects of health. So length of life, for example, in the top graph here on the screen, you have the difference in the full size of the bar shows the difference in life expectancy between different groups in the UK. Now, this is just the pure inequality in health. So if we order everyone from the least healthy to the most healthy, what you see is that the least healthy group are on the left-hand side, the least healthy fifth of the population, and they have a lower life expectancy, just under 80 years. The most healthy group on the right-hand side, group 5, the healthiest fifth of the population, have a life expectancy above 85 years. So there's a difference in life expectancy across the population. But we also see differences in the amount of life years lost to illness, so a difference in morbidity. So the white portion of those bars shows the difference in years lost to morbidity, and that's also larger in the sickest group compared to the most healthy group. If we look at the lower set of graphs, we're associating these differences in health with socioeconomic status. And this measure that's shown on these bottom graphs, this IMD, is the Index of Multiple Deprivation. So it's a measure used in the UK, and it looks across different domains of life, including things like employment opportunities and education, and just characterizes each area in England into it's indexed up from 1 to 100 across the whole of England and characterizes each area according to the area level socioeconomic disadvantage. And then we can group the population into quintiles again, into fifths, with IMD 1 being the fifth of the population that live in the most disadvantaged areas, and IMD 5 being the fifth of the population that lives in the most advantaged areas. And again, we see these differences in health between these groups, differences in life expectancy, differences in quality adjusted life expectancy, and differences in disability-free life expectancy. So tackling these systemic and persistent inequalities in health that we observe is a public health priority in countries across the globe. So this isn't just a particular UK perspective that we're talking about here. The healthcare sector is one determinant of health and a key resource that we may be able to use or leverage to improve health in an equitable manner. Now, if we think more broadly about how these health inequalities came about and the social determinants of health, often the causes of the extent of these health inequalities may lie outside the health system. So there is a first step to ask about how much we want to prioritize addressing these health inequalities within the healthcare system. It might be very inefficient, for example, to try and use our healthcare resources to try and address some of these inequalities when things like redistribution of income or addressing differences in levels of disadvantage might be the better approach. But there is still an element, and there is still evidence that there is public policy desire to use healthcare to also address some of these inequalities. We're interested in ones that are avoidable and that are amenable to intervention and that are considered to be unfair. So we've used socioeconomic disadvantage here. That's actually embedded in the Health and Social Care Act in the UK as one of the priorities for healthcare. And the National Institute for Health and Care Excellence has a duty to pay regard to these particular health inequalities. We've got people on this course from a range of different settings, and so the actual equity focus of your analysis might be slightly different. It depends on the decision maker, the decision that you're seeking to inform, and the setting in which the decision is being taken as to what's those equity characteristics. What is the health inequality that's considered to be unfair? But once you've identified that, then the things that we talk about within this course will apply across those different types of concerns. So now we come on to the economic evaluation part, the resource allocation in healthcare problem. So given finite resources, which is the situation we all find ourselves in, then priority setting for new healthcare programs is unavoidable. What we see around the globe is a lot of use of cost effectiveness analysis to help inform resource allocation decisions in healthcare. cost effectiveness analysis often focuses on maximizing health benefits for the lowest cost. And while maximizing of health benefits is important, it's only one of several policy objectives. In fact, you rarely see a policy document that talks about maximization of health benefits as the goal for healthcare. There's often talking about improving population health, but we can't necessarily say that improvement is always the same as maximization there. Now, in economic evaluation and cost effectiveness analysis, we're very interested in the opportunity cost. We use cost effectiveness analysis and our decision models and the evidence that we bring together to estimate the incremental or added cost per additional unit of health outcome from introducing a particular program that we might be evaluating. And from this, we can calculate a statistic known as the incremental cost effectiveness ratio. So this is the cost per additional unit of health that we can expect to see if we were to opt to introduce this particular program. And this can be compared to the cost per unit of outcome that could have been achieved with alternative uses of resources. This is the opportunity cost. If we did the next best thing with those same resources, what's the outcomes we would have gotten? And are we doing better or worse by investing in this program instead of those other things? Now, this opportunity cost can be reflected within a cost effectiveness threshold. And by comparing the incremental cost effectiveness ratio to this threshold, we can provide some information about whether or not this program gives you better benefits than alternative activities. It establishes a ranking or a preference order of different programs. We can rearrange this equation where we look at the incremental cost per unit of health gained to look at net benefits, or maximizing net benefits, either net health benefits or net monetary benefits. The key thing to be addressed by health technology assessment bodies and decision makers in this area is that by investing in one program, the recipients of that particular program, that intervention gain, but potential recipients of the alternative interventions that we could have invested in forego benefits. With our objective to maximize health and with the standard approach to cost effectiveness analysis that's applied in many HTA bodies, all health gains are implicitly considered equal. So the health that you gain from the program is equally exchangeable with the health that you forego from these other investments. And we can depict the decision problem very simply using the cost effectiveness plane. So on the y-axis, the vertical axis here, we have the change in cost with the program. On the horizontal axis, we have the change in health with the program. And the rate at which we could convert our resources into health is shown with this slope K, which is the cost effectiveness threshold. And we're interested in where our program we're evaluating lies on this plane. So if it lies at the place where the blue dot is, we can see that the incremental cost effectiveness ratio is below the threshold. We're changing our resources into health at a better rate than we could do with other activities. That would be regarded as cost effective. Displaying the information on the plane, we've got some very quick decisions that we could reach depending on where we fall in the 4 quadrants that it defines. So if we're in the top left-hand side of the plane, it's a program that's more costly and provides less health than the alternative you're comparing it to. So we would say that's dominated. It's more costly and less effective. We don't want that. And in the bottom right, we've got a dominant program that's less costly and more effective. So it seems like a win-win situation. And in the 2 diagonals, the northeast and the southwest is where we have the trade-off quadrants. And what we're trading off there is the health for the recipients of the program and the benefits we could have achieved with the alternative uses of the resources. But that, as I said, implicitly values all of the health gains equally, no matter who gains and who loses. It views an additional unit of health as measured by a quality adjusted life year, for example, as being a QALY is a QALY is a QALY, no matter to who it accrues. but people may value health gains differently according to the characteristics of the people that benefit from them. It might be related to things like disease severity. It might be related to their lifetime health experience and maybe their shortfall from some minimum life expectancy that we would want everyone to have. It might be related to non-health related disadvantage, so socioeconomic position. When we're doing these evaluations, the decision makers involved may be informally taking into account health inequality impacts, but what they typically see is the information about the program that you are evaluating and the characteristics of the people that stand to gain health if you recommend the program. What they generally don't see is information about who would lose out. So who's foregoing those benefits lost by the opportunity cost. So we know that in health technology assessment, cost effectiveness analysis information is one element that goes into informing the decisions that might be taken at NICE, at CADITH, or at other places, and that there are these other considerations. But the information that's provided on those other considerations is generally a lot less compared to what we get in terms of information on cost effectiveness. And this course is addressing how you might bring health inequality impact up to the same level of information as the overall gain on impact on population health. This is very important because when we're taking these decisions, we have to be aware that the policy or program that produces the most health, that maximizes health, might not minimize inequality. We can find situations in which health interventions actually increase health inequality. We know that uptake, adherence, and efficacy may be better in socially advantaged groups. We see this sometimes with screening conditions, interventions. People may be more able to uptake them or more willing to uptake them if they're more socially advantaged. And then what that leads to is intervention generated inequality. So this is not only health inequality that's avoidable, but it's something that's been created by a policy decision to provide a particular intervention. You might also see that the policy that maximizes health is not the one that minimizes inequality because it's more costly to deliver interventions to socially disadvantaged groups. So if we're interested in fair delivery, in making sure that everyone can access the intervention equally, we might need to pay more to make it accessible, to make it usable in socially disadvantaged groups, which can make it look less cost effective from a health maximization point of view. Whereas we see policy documents that focus very much on this desire to reduce health inequalities and improve population health, they often fail to acknowledge this potential conflict, this potential trade-off between health improvement in terms of population health maximization and health improvement in terms of reducing health inequalities. And most countries report a shortage of evidence for effective interventions to tackle inequalities in health. So there's something they want to do about inequalities in health, but they don't have the information about which interventions are actually going to provide the results they're interested in. So that's just a quick overview of where we're up to now. I don't know if there are any questions or any comments that anyone wants to address at this point before I move on to talk about measuring inequality. I mean, is that all reasonably clear so far? I can move on to inequality, as I say, just pop it in the chat box or say something if you want to mention anything at this point. Okay, so I'll move on to talk about how we measure inequality. So this course is about incorporating inequality in economic evaluation, and I'm really talking about quantifying impacts on inequality. So that means I'm going to talk about basic numerical measures for how we describe the extent, the magnitude of inequality, and how we can measure the change in inequality produced by an intervention. So we see widespread monitoring of the extent of health inequalities and their trends. This is kind of akin to a burden of illness type approach to looking at the extent of differences between different population groups. And there's a range of indicators that are applied to describe the inequality between groups. They range from very simple measures that are easily interpreted, they're quite intuitive. So it might be the life expectancy gap. This group can expect to live 10 years longer than this other group. You might get regression-based measures such as a slope index. So what that does is describe the degree of change in health according to some characteristic. It's quite a simple measure. It's quite common in public health. You see the slope index of inequality and the relative index of inequality. And these type of simple measures work best when you're looking at a fairly simple linear relationship between the characteristic you are interested in and the change in health. And I have a diagram later that shows you a bit more about what I mean by that. And then we move on to much more comprehensive measures that capture the whole of the distribution. So they take into account every individual in the population's health and use that to calculate an overall summary of the extent of inequality in that distribution. These advanced entropy type measures are useful for reflecting everything that happens, all the changes that happen, and they're very comprehensive, but they can be a bit less intuitive and a bit harder to understand. So if we think of things like a Gini coefficient, then that would capture changes across the distribution. But the actual number attached to a Gini coefficient might be difficult for a decision maker to interpret in terms of how important is that number compared to something like a life expectancy gap. We also have to be careful with the qualities of the measures that we use. So particular entropy type measures, or ones that take account the whole distribution, can often implicitly include weighting on different individuals. There are extensions to these measures to try and make that weighting explicit and allow you to adjust it. But it's just to be careful with your choice of inequality measure, because some of them will actually imply a value judgment that you might not realize when you're using it to just try and describe numerically the extent of inequality in a distribution. So we've got all these different ways we can measure inequality, different things we can report. And they're correlated, but the conclusions we come to about the magnitude of inequality and the trend and change of inequality are going to be different across these different measures. Some of the things we might focus on are things like absolute inequality, so one group living 10 years longer than the next, or we might look at relative inequality, one group living 10% longer than the next. Those two things won't always move in the same direction. We might look at shortfalls, so how much less than some kind of minimum standard of living do different groups have. Each of these things will give us a slightly different picture about inequality. And this can be a bit daunting sometimes, because in the approach that we take to cost effectiveness analysis, many of us will be used to using a reference case or recommendations for how to approach different aspects of the analysis. And that helps reduce our methodological uncertainty about, for example, whose preferences count. Should we use EQ5D with general public preferences to estimate QALYs? Often that is dictated by the particular decision maker that you are seeking to inform. With inequality measures, because they're less commonly used, you may be left without much guidance as to what is the preferred inequality measure of a particular decision maker. The approach that we take and would suggest is to calculate a range of measures, and actually that information can be useful. So you might calculate both absolute and relative inequality, be able to demonstrate that the intervention looks to have a positive impact on both of those things, and that would potentially strengthen the case there. This widespread monitoring of health inequalities indicates overall progress at health inequalities, but at the moment it's not really targeted at evaluating the effectiveness of specific interventions. So that's what we're aiming to increase the amount of, looking at the impact of interventions on inequality. But you should be able to find in most settings now some information on the kind of baseline level of inequality in the distribution of health that you're interested in. And we do need this for this type of analysis, particularly if we're looking at impacts on relative inequality of an intervention. So going back to some of the common measures. So we can have simple gaps and ratios between groups. But if I told you the gap in healthy life expectancy between the richest and the poorest, or between the most healthy and the least healthy, then if I look at the impact of an intervention on that, it's only going to be sensitive to the extremes of the distribution. It's going to miss out what happens to everybody who falls in the middle. If I look at the slope index of inequality, that's a gradient or slope in the case of just one variable we're interested in, fit to the health distribution. And it works best where ordinary least squares type approaches work best. So where there's a linear relationship between the factor that you're interested in and the health outcomes. So if you see a slope index of inequality presented, a slope index of inequality of 10, for example, would mean that the most healthy group has 10 more QALYs than the least healthy group in that analysis. So whatever characteristic is used to calculate your slope index, that's it. The difference that you see, the slope index 10, is between the highest and the lowest on that measure. You can convert the slope index into a relative index of inequality by dividing through by the mean health, and it's the relative change when you move from the least to the most healthy. So a relative index of 0.1 would mean that the most healthy has 10% more health, more QALYs, for example, than the least healthy. We are going to talk a bit more in this about an entropy type measure, the Atkinson Inequality Index, which summarizes the whole distribution and also has a range of desirable mathematical properties that make it quite suitable for economic evaluation. So on this picture here, I've got a distribution of health from the least healthy to the most healthy, fifth of the population. And if I calculate a slope index, crudely, what I'll be doing is drawing a straight line to fit across all of these bars in this histogram. And I can report the slope of that line, or I can divide through by the mean health and report the relative index of inequality. So if a straight line looks to be a good fit here, then a slope index and measuring how an intervention impacts the slope index might be a reasonable approach to take. The advantage there is also that you're using a metric that might be commonly understood by your stakeholders who work in public health or other areas where the slope index might be commonly reported. However, if you have a situation with a more curved appearance in your distribution, then the slope index is going to be inappropriate and might not very well reflect the impact of the intervention on inequality. If we look at inequality indices, things like a Gini coefficient or an Atkinson inequality index, they summarize the departure in a distribution from perfect equality. So in this diagram on the right hand side here, I've got the percentage of population health, and on the bottom you've got the percentage of the population that enjoys that percentage of population health. So perfect equality is represented by the diagonal. So 20% of the population would have 20% of the population health. And the Gini coefficient and similar measures will measure how far you are from that perfect distribution, roughly in terms of this area between what you observe and the line of perfect equality here. Now, with these measures, there's a weighting applied, and the health to different people at different points in this population is valued or weighted differently depending on your rank in the distribution. The Atkinson index has an explicit inequality aversion parameter, this Atkinson E, that determines the weight applied to different people within the population. Now, it's not as simple as a weight applied to each person dependent on their rank, because it does depend on the overall level of health in the population as well. So a particular value of Atkinson E doesn't define a particular weight, but we can back calculate from a particular value of an Atkinson E the weight that is applied to different people in our distribution. However, we can directly estimate this Atkinson E with some social preference surveys, and we'll come on to that in a bit. So I've just shown the formula here to for how you calculate that. Now, if we calculate this Atkinson E based on a population survey that indicates the priority people give to reducing health inequalities compared to increasing overall levels of health, then the Atkinson Index can summarize to us the extent by which overall social welfare, so the overall benefits we get from a particular program, are reduced by the current level of inequality in its distribution. And that's very useful for the decision problem we're seeking to address. So if you've got a program that improves health but increases inequality, what you'll get is a reduction in the gains from that program as a consequence of the extent by which it increases inequality. So how do we elicit
Excuse me, Susan.
Oh, yes.
Can you just say that one more time?
Okay, so
you were talking about if a program improves health and reduces anyway. If you wouldn't mind.
Yeah, so I'll go over that a bit. So if I calculate the Atkinson Index for the say the distribution of health within the UK, that's unequal. So what I get is that the actual value of the level of population health is less than the simple sum of population health because it's penalized for being unequally distributed. And the same applies for if I were to calculate the health gains from an intervention. If I were evaluating how a program affected population health and it primarily provided health gains to advantaged groups, then I would value those health gains less because it would exacerbate inequality. So I would penalize the program for having increased inequality. I would value health gains from a program the most if they were falling in the people at the bottom of the distribution. So that's broadly what that measure is doing. Does that help?
Perfect. Thank you.
Okay. So in terms of eliciting inequality aversion, so this Atkinson E is the amount by which our welfare, the utility we gain from an outcome such as health, is reduced by inequality in its distribution. We want to know this Atkinson E. So what do we do? Well, one option is to ask people in a survey to choose between different options where one option provides more overall health and the other provides a lesser amount of overall health but has a more equal distribution. And then we keep varying the amount of overall health or the amount of inequality until you reach the point of indifference. And that gives us an idea what the Atkinson E, what the level of inequality aversion is. So on the left-hand side here, there's an example of a case from Proper et al. Who were looking at cancer risks between different regions. And they could ask people preferences for program A or program B in terms of which program would be preferred. Now, in both cases, they provide the same amount of overall cancer risk in a population, but what you can see is program A, that cancer risk is concentrated, particularly in region 2, whereas in program B, it's evenly spread across region 1 and region 2. So if you're egalitarian, if you have a preference for equity, you would prefer program B. Now, if you look at the right-hand side, what you can see is a different question where it's asking about program A and program B that provides a gain in life expectancy. Now, in the top two sets of programs here, we've both got total gain of 10 years, but after you add the change of the program in, the way that it's distributed in program A, it gives an additional 7 years to the richest fifth of the population and an additional 3 to the poorest fifth, versus program B, which is the other way around. So program A increases absolute inequality and increases health. Program B increases health but reduces absolute inequality. But then you might ask people, what do they prefer about program A that gives 10 years with this distribution, so 7 years to the richest group and 3 years to the poorest group, versus program B, when program B only gives you 9 years overall. So it's less effective, less improvement in population health, but again, it's reducing that gap in healthy life expectancy. So we could keep reducing the total gain with program B until we find the point at which a person is indifferent. And that gives you an indication of how much overall population health they would be willing to trade off for a reduction in health inequality. That's essentially the trade-off we're interested in here to get our measure of the impact of a program on overall health and health inequality. So that's talking about measuring inequality. So I just want to pause at this stage for a bit of discussion and for any questions. And also we'll probably make some time for 5 minutes screen break as well before we get on to the next thing. So I was just wondering, quick poll everyone, I can stop sharing actually now, and that might make it easier to have a discussion. So has anyone ever calculated any measures of health inequalities before in their work?
Hi, Susan, we have a question from the chat box. Do you have any examples of published studies that estimated the Atkinson index?
Yes, so we've applied it ourselves in our own economic evaluation. So we have some examples there. The Atkinson index was initially developed by Tony Atkinson, and the application was in income primarily. So looking at income inequality and preferences for reducing that. We did an examination of whether it would be an appropriate statistic to use in health, because one of the things you have to consider is for something like the Atkinson index is the difference qualities between income and health, of which there are. So income's unbounded, but health obviously is bounded to some degree, and you can transfer income between people directly, but you can't with health. But we looked at it, and the mathematical properties are suitable for applying it to health as an outcome measure. But it's been applied in those kind of settings. There's a number of studies, though, have started to look more at inequality aversion. So there's a range of studies that measure the extent of inequality aversion and relate it to things like risk aversion, and look at whether people are averse to pure health inequality. So that's difference in health outcomes between the sickest and the healthiest people in society, or whether it's more of a bivariate inequality concern. So they're concerned about inequality between the poorest, the most disadvantaged, and the richest. What the evidence is suggesting is people are more concerned about this income-related socioeconomic disadvantage related health inequality than they are about pure health inequality.
And there's a question about the Gini coefficient. Yeah, you can check the chat box.
So the Gini coefficient is something that you can use to express the extent of inequality, but it is one that has this kind of implicit weighting when you are evaluating whether the extent by which it's increased or decreased, and at what points in the distribution adding health has the most impact on the change in that measure. But Adam Wagstaff and others have developed and extended the Gini coefficient to allow you to alter that and to make it a bit more like how we're using the Atkinson index. So in that way, it can be very similar there. So Gini coefficient would be an appropriate one to use as well. The reason we like the Atkinson index, which we'll come on to later, is it allows us to easily calculate a single summary measure, the equally distributed equivalent health, that will give us a single kind of index. We can have net health benefits, we can have cost effectiveness metrics in terms of equally distributed equivalent QALYs. and use them in exactly the same way that we use QALYs. And a Gini coefficient wouldn't allow you to do that conversion. So it's got slightly less utility there, but it's if you use the extended version, it's perfect as a measure to summarize an inequality impact, for example.
Just a follow-up question. We're kind of considering also how this applies to the US market given insurance, right? So for example, just a corollary would be, value of hope and insurance value. We wouldn't necessarily want to take estimates from a place that doesn't necessarily have these big insurance pools. So I guess one of my questions is, has anybody applied, have you seen any examples of that done in a market that does have kind of this insurance buffer as well? And do you think that would play a role in being able to kind of, what's the transferability of something done in another country, as a start back to the States? And do you think there's any role of kind of our large insurance pool in impacting how we might be able to apply that?
So I think that in terms of the transferability between countries, there are a couple of big differences that would mean the US setting is very different to the UK setting. What we've done in developing this, we've been doing it mainly in a situation with universal health coverage. And so with that focus on purely health outcomes and makes an amount of sense when you're looking at a situation where everyone has access to the health program that you are evaluating. When you take it into a situation where you don't have universal health coverage, then you might want to look as well at things like extended cost effectiveness analysis that also bring in this element of financial risk protection. Now, in the extended cost effectiveness analysis literature so far, they haven't tended to use these summary measures of inequality impact. One of the challenges you get into when you try and do it across two domains, so we're focusing within the health domain here, but if you try and do it across both the health and the income domain, you run into issues about what is the inequality concern? Is it concern for income inequality? Is it concern for health inequality? Is it a bit of both? And factors like that. And it can be difficult to disentangle those two things. So it does become more complicated doing it within that setting. But I have seen focus with some studies in the US where this is of interest in general in public health in the USA in the same way as in the UK, and also a bit of interest within insurance plans. And it makes sense that if there are public preferences for reducing health inequalities, that actually they would be concerned if their insurance plan was having this kind of redistributive effect and mainly benefiting the best people. That would be useful information to provide to consumers, and you might be able to, as an insurance plan, explain that you have this benefit of not increasing inequalities, or that you've taken this into account. I think there's some interest in it from a more kind of looking at how the fair insurance market, so whether or not particular insurance programs actually discriminate or disadvantage particular groups of their members as well. So I think it does have some application there, but I think the methods we're talking about here are mainly focusing on just a health domain rather than health and income together.
Thank you.
There's a question here about calculating inequality aversion for all inequality factors that are important. And yes, so what we've looked at is primarily pure health inequality aversion. So that's inequality to any differences in health. And we've looked at it by socioeconomic advantage, but it would be different if you were looking at it along ethnicity grounds or something else. So if you can do it, if you can use the pure health inequality aversion and do some calculation before you get to that to describe the level of inequality that you're interested in. If you look at some of the work by Fleurbe and Schockhart for trying to differentiate between differences in health that we think are fair and expect to see and differences in health that are unfair. If we can adjust first for those factors and calculate the distribution of health that we're interested in. So we're looking at an adjusted distribution of health that has removed, for example, you can do it either way around. You can remove all the fair causes of inequality, or you can remove all the unfair causes. Then you might be able to apply a singular level of inequality aversion to that adjusted distribution if you first calculate that. That avoids having to estimate a load of preferences for a lot of different equity considerations. But if you're just calculating an unadjusted health distribution, so you're just measuring people's quality adjusted life expectancy, then yes, you need to be taking into account for the context of the decision that you're seeking to inform for the equity concern, what is the equity concern and the level of preference given there. So just got a question about what's an example of a fair inequality. This is contentious. So the differences in terms of fair or unfair would be different. But for example, if you like to go skiing or racing fast cars and this reduces your life expectancy, some people would say that's perfectly fair. That's a choice that you made. So you're less healthy. You like to go base jumping, but we don't want to try and correct for that by prioritizing you for health interventions. Another one that comes up is the difference between men and women. So women live longer, but generally in less quality of life. So is it unfair that women have longer life expectancy than men? Is it just biological? There's some arguments there, but the unfair stuff comes back to things like your life circumstances. So you were born in a disadvantaged area, your parents were poor, and through no kind of freedom of your own choice, you have a lower life expectancy. So that'd be more something that would be considered unfair. Okay, so I think what we'll do is we'll just take 5 minutes screen break here if you want. Take a break from staring at the screen, and then we'll come back at well, by my watch it's 6 past. So if we come back at about just after 10 past. Okay, I think I'll continue with the presentation. Hopefully everyone had a quick chance to stretch their legs and take a break from the screen. So now we've talked a bit of an overview about health inequality or health disparities, and a bit about how different measures we can apply to health inequality. And now I'm going to talk very particularly about how you might adapt your cost effectiveness analysis, your economic evaluation, in order to estimate health inequality impact for an intervention. So what we need to do is adapt our cost effectiveness analysis to look not only at the impact on total health, but also the impact on inequality. So we want to estimate our distribution of health. So this is our distribution of health across our subgroups of interest, so by socioeconomic status or by other factors that you might be interested in. Now, if you remember, the problem with economic evaluation focuses on not only what the intervention provides us with, but what's the opportunity cost in terms of what we forego by investing in that particular intervention instead of the next best alternative. So we need to know the distribution of the benefits of our intervention, but we are also interested in the distribution of our opportunity cost across those same subgroups of interest. Once we get both of those distributions, we can calculate the net health benefits, the net health impact for each of our subgroups. If we're interested in relative inequality, what we can then do is add those net health impacts onto our baseline distribution of health and see how it's changed. If we calculate our inequality measures that we've chosen on the distribution of health without the intervention and the distribution of health with the intervention, we get to summarize how the intervention changes the distribution in terms of changes in inequality and changes the level of overall health. So that information we're still providing on the change in overall health, that net health benefit, we're still providing that cost effectiveness analysis information in the same way that the existing ones do, but we're adding in an aspect of inequality measure. Now, we've done this typically so far in terms of using subgroup analysis within our models. But for those of you that use simulation models, what this means is that you would also condition your individual simulations on characteristics, for example, related to the equity parameter of interest, and then make sure you're simulating sufficient individuals from each of those groups to estimate your parameters. But we've done it broadly in terms of subgroups. So in terms of the distribution of benefits from your intervention, we want to look at who gains and by how much. And we go through our cost effectiveness model and we look at the parameters or inputs and question whether they differ systematically between these subgroups that we're interested in. And some things that you're going to want to look at would be things like treatment efficacy. Does it work better or worse in particular groups? Adherence. Does that look different in different groups? Quality of life from different events, and things like baseline risks and how this interacts with treatment efficacy. Now, one particular thing which we need to take account of here, which you don't necessarily always account for in cost effectiveness analysis, is things like treatment uptake. So because we're not concerned about the impact on the distribution of health with standard cost effectiveness analysis, we can take a kind of per person, per individual perspective, and it will scale up and down naturally to a population level impact without any difference in whether or not we judge the treatment to be cost effective. However, one of the biggest sources of inequality in the type of healthcare interventions we provide is how many people actually use that intervention. So we don't want to know just the cost per QALY per user, but per person who actually uptakes the intervention. We need to compare that across groups in terms of how many within each group would actually use the intervention. So we need to explicitly take account of uptake, which you might not normally do in a cost effectiveness analysis. And we also want to look at the distribution of health opportunity costs. Now, our cost effectiveness models typically estimate costs and health outcomes from associated with a particular condition or for a particular population group. But we're not interested in where the costs fall. So who is actually using the resources? We're interested in where the opportunity costs fall. So who would have benefited from alternative uses of those resources? So we're going to use the model to calculate total costs in each group, but then we need to convert that into our health opportunity costs. Within the UK, because we have our the universal healthcare coverage, the National Health Service, what we know is that if we deploy NHS resources to a particular intervention, then the alternative uses of those resources could have benefited anyone within the UK. So it's not necessarily the same group that the intervention benefits from. So if I fund something in Alzheimer's, that might predominantly benefit older people, but the other uses of resources could have benefited young and old people. Or if I fund something in breast cancer, that'd be more likely to benefit women than men. And the other uses of resources might have had a different gender distribution of benefit. So we need to take account of that. Within the UK, we've estimated this, and we've estimated the different groups in terms of age, gender and socioeconomic disadvantage that benefit from NHS resource changes in NHS spending at the margin. We know that those changes benefit the socially disadvantaged groups more. So if you're introducing a more costly intervention, it's taking away from things that would have likely benefited disadvantaged groups more than advantaged groups. What this means is the opportunity cost, has a kind of inequality increasing impact. So to reduce inequality overall, to have a net reduction in inequality, we need a policy to not only benefit socially disadvantaged groups, but to do so by more than current alternative activities we could be doing. So I showed you a cost effectiveness plane earlier that kind of depicted the decision problem from a health maximization perspective. And we have an equivalent here in terms of inequality. So that's the health equity impact plane. It has 4 quadrants, but the interpretation is a bit different. What we've done is we've condensed our cost effectiveness analysis information into net benefit, and that populates the y-axis, the vertical axis. So something in the top half has a positive net benefit. It has an incremental cost effectiveness ratio below the threshold. It increases population health. Something in the bottom half would be cost ineffective. It would have an incremental cost effectiveness ratio higher than the threshold. It would have a negative incremental net benefit. We've added information on the net impact of health inequality on the x-axis, on that horizontal axis. So whatever measure, your slope index of inequality, your Atkinson index of inequality, if you're on the right-hand side, it reduces health inequality, and if you're on the left-hand side, it increases health inequality. So if we're comparing just 2 programs, so we've got our intervention and the comparator represented at the origin. So our intervention is in the top right quadrant. It increases health overall compared to the comparator and reduces health inequality. This would be a win-win situation, for example. And there's no trade-off there. It improves population health and reduces inequality. Likewise, in the bottom left, you've got something that reduces population health and increases health inequality. There's no trade-off there. Those are both bad outcomes as far as we would be concerned. But in the bottom right and the top left, you're in a trade-off situation. So in those trade-off quadrants for cost effectiveness analysis, you have the cost effectiveness threshold to determine whether or not the increase in health is worth the increase in cost. In these trade-off quadrants, this is where this inequality aversion, this willingness to trade between population health and reduction in health inequality comes into play to determine the ranking of interventions that fall in those trade-off quadrants. Now, there's different ways you can bring equity into economic evaluation. There's cost consequences analysis. You could just present the impact on population health and health inequality in disaggregated form. So if you've done your subgroup analysis, you could just present the changes in health in each subgroup separately. Then you're kind of pushing forward the weighting or the trade-off to the decision-making process. So the person interpreting the results has to determine, for example, if it is in one of those trade-off quadrants, whether or not that the intervention is desirable. There's also a challenge with inequality in that it can be difficult to judge the net impact just by looking at those disaggregated ones, so some summary measure can be useful. Another approach you can use is equity constraint analysis. So you can actually say, I'm only going to improve interventions that have an equal impact across different groups. So you can put in some kind of constraint there. Or you can estimate the inequality cost from maximizing health. So you can say, if I choose the policy that maximizes health, what do I pay in terms of increased inequality? These type of things make things more, the trade-offs more explicit, but don't incorporate any kind of weights. So you're just calculating a penalty or imposing a penalty on things that change inequality, but it doesn't reflect a societal preference for the extent of inequality you might be willing to trade for improvements in health. We can bring in equity weights, pre-specified equity weights. For example, we could calculate equity-weighted QALYs as our measure of outcome instead of QALYs, or we could do that in a multi-criteria decision analysis type framework. So we could summarize our cost effectiveness results with the incremental cost effectiveness ratio. We could provide a summary of the inequality impact, and then through an MCDA process, define a weight for those kind of things. That would allow for different weights to be made, to be used in different circumstances, but then it does require that each time the decision-making process allows for those weights to be developed, and it also raises the possibility of some inconsistency across decisions if you define the weight within each decision. There's a challenge with using a pre-specified set of equity weights. One of these is that none of us are associated with a single characteristic that might describe an equity concern. We have multiple characteristics associated to us that might give us priority to different degrees. And some of our equity relevant characteristics can change over the course of our lifetime. When we're using these pre-specified weights, we need to know not only what weights to apply to the intervention benefits, if we're calculating equity-weighted QALYs, we also need to know what weights to apply on the opportunity cost side. So the same set to calculate equity-weighted QALYs foregone. So that can be challenging. And ultimately, because we have the same resource constraint no matter what we do, increasing the weight of health gains to one group implies decreasing the weight for another. So it's redistributive for what we can do with these resources. So it's not always just going to increase the value of interventions for particular groups. To do that, you have to balance it out by decreasing the value in other groups. So I've talked about some of the measures already, and just coming back to why we like the Atkinson index for this application is that we can calculate the equally distributed equivalent health. So if we use Atkinson's E to summarize the level of inequality, we can take 1 minus the Atkinson index, multiply that by the mean level of health, and that gives us the equally distributed equivalent. That's the level of population health that, if equally distributed, would yield the same social welfare as the distribution we're evaluating, the one we observe. So if I have a distribution of health that's unequal and favors the better off, then I would be happy. I would accept a distribution of health with less population health overall, but where everyone had the same healthy life expectancy. And that's the equally distributed equivalent. And if we calculate this for all our interventions, we can rank our interventions in terms of their impact on net equally distributed equivalent health. So that's just a brief summary there of how you go about doing that. But Fan's going to go through a worked example next to show you in a bit more detail. So I'm going to stop sharing my screen and allow Fan to take over, but I can look at some of the questions that have popped up while Fan's getting her slide set up. So in terms of treatment, there's a question about whether treatment adherence could vary systematically by subgroup. That certainly is a concern. You should build that in. And there's a question about, do you cost out interventions that are required to additionally enhance adherence separately? Yes, we would recommend that. So you could evaluate, I guess, a set of different policies. So an intervention on its own and an intervention plus a modification that address the adherence differences. Those are different investment options. You might choose to go to the intervention on its own, or you might be willing to pay for the enhancement, the modification, to reduce the impact. So yes, you could evaluate those things separately. In terms of the slides, we can share the slides and the references, yes, afterwards. I can copy them now and put them in the chat box while Vanna's
I sent a PDF file in the chat box.
Cool.
Yes,
okay.
Maybe I can send it later. Yeah, you will get them. Yeah. So I will help you guys go through an example. We use this method to assess the inequality impact in economic evaluation. So this example is about the NHS smoking cessation services. And according to the NICE public health guidance, there is some evidence showing that the stop smoking interventions can be considered cost effective. So I also included the structure of this model. Actually, this model is quite straightforward. It only includes 3 health states. The start of the cohort, everyone entered the model via the smoker status. So they may have the risk of death, risk of developing those smoking-related diseases, and they may quit smoking and become the formal smokers. As there are large differences by the level of deprivation in smoking prevalence, risk of death, and the intervention uptake. So we think it may be interesting to know whether the intervention have the same or different impact for people differing in socioeconomic status. So here in this example, we define the level of deprivation using the English Index of Multiple Deprivation, IMD. So this IMD is the official measure of socioeconomic deprivation of living areas in England. So all the small living areas, including on average about 1,500 residents. So each of those small living area will have an IMD score calculated using information from 7 domains: income, employment, education, health, crime, housing, the living environment. So the IMD score can classify all those small living areas into 5 equal size groups that result in the IMD 1 representing the most deprived, the most 20% deprived areas in England, and IMD 5 representing the least deprived areas. Okay, so the next, here is the steps we analyze the data. So I just summarizing them into 7 steps. So we will go through them one by one. So first step is we need to estimate the incremental costs and the incremental health benefits inequalities for each IMD quantile. This requires the extension of this to the current CEA model. This also requires evidence about how the key model parameters vary by IMD. So we, after searching the databases literature, we included those key model parameters that vary by IMD. Their smoking prevalence, mortality, the risk of death, risk of developing smoking-related diseases, their health-related quality of life. And we also consider the difference related to the intervention itself. So they may differ in intervention effectiveness. This is the probability of quitting smoking for the smokers who use that intervention. And also the intervention uptake may also different according to their socioeconomic status. So we summarize those model parameters using the concentration index. It can show both the direction and how unequal this model parameters is. So we can have a look at each of them. So first, the smoking prevalence. So the trend is quite obvious. People living in the least deprived areas, they are less likely to smoke. And for the mortality rate for smokers, so the IMD1 is this one. So people living in the more deprived areas, they have the higher risk for death. And for the probability of quitting smoking, if we use the IMD1, the most deprived group, as a reference, people living in the less deprived areas, they are more likely to quit smoking if they use the intervention. In terms of intervention uptake, people living in the less deprived areas, they are more likely to uptake this intervention. Yeah, so based on those parameters, we can estimate the incremental cost and the incremental benefits for each IMD quantile. Because the original model estimates the results for the whole population in England, so those are the population level estimates. The incremental benefits, incremental cost for the 5 quantiles. So the next step is to convert the total incremental cost to the health opportunity cost. So just sum those values, and we calculate the total health benefit, total health opportunity cost using the 20,000 per collie, the threshold, and this is the total health opportunity cost. So step 3 is, as Susan mentioned, the distribution of health opportunity cost is not equal. It favors people living in the more deprived areas. So here, 26% of the health opportunity cost for the IMD1. So based on those values, we can calculate the health opportunity cost for each IMD quantile. And this leads to the next step, to calculate the incremental net health benefit for each IMD quantile. We have this direct health benefit from the intervention. We have the health opportunity cost. So the net health benefit, incremental net health benefit is the direct health benefit minus the health opportunity cost. Those are the incremental net health benefit for the 5 quantiles. So the next, because those are the population level estimates, we also have the population size for the 5 quantiles. We can calculate the individual incremental net health benefit for a typical individual in each of these IMD quantile. So based on that, we can see there is inequality in this net health benefit if e-cigarette intervention assessing in this example, if e-cigarette is provided, the predicted, the estimated incremental net health benefit is not equal for the 5 quantiles. It's, for example, for an individual in IMD1, the most deprived group, the incremental net health benefit is 0.001. While for an individual in IMD5, the least deprived group, the health benefits is more than double of the benefits for those living in IMD1. So the next step is we will add those individual incremental net health benefits to the baseline distribution of health. This will help us obtain the distribution of health with the intervention. If the intervention is provided, what the health distribution would be. So this is the inequality in baseline health. The baseline health is measured using the quality adjusted life expectancy. There is some difference here. So for example, people living in the IMD5, the least deprived areas, they will have nearly 11 years longer in full health than people living in the IMD1, the most deprived group. So we add those health benefits to the baseline level of health. Because this incremental net health benefit is so small, so we only we multiply them by 1,000 to allow them to be displayed in this single figure. So the results are here. So we have the distribution of the baseline health, the baseline level of health without any intervention. And we have the health distribution of health if e-cigarette is provided. So next step is we need to calculate the inequality measures on the pre and the post-intervention health distribution to summarize the health inequality impact. So as Susan introduced just now, there are different types of measure we can use, like the absolute inequality measures, the relative inequality measures, and also we can use this inequality aversion parameters like alpha and epsilon from Cole and Atkinson index. Those will indicate how much priority do we give to the worth of people in the distribution. And those index range from 0 to infinity. The higher this value, the more importance people put on the health benefit for the worst off people. Yeah, so here let's have a look at the results. So for both the absolute inequality indices and the relative inequality indices, we can calculate them for no intervention, the current level, the baseline level, and the index for if the e-cigarette is provided. The higher this value, the more unequal the health is. So from all those results, we can see the indices for e-cigarette are much higher, not much higher, higher than those for the no intervention. So we conclude that the inequality, it increases inequality. So I put a red color here. And also we can calculate the trade-off between the health and the equality, because it can combine concerns for maximizing health with a concern for minimizing health inequality. And it is a standard functional forms for this trade-off in the general economic inequality literature. It can assess a full distribution rather than the two extreme groups. But here we need to make it clear which inequality aversion we will be using. So here I use both the Cole and the Atkinson index. So we need to calculate equally distributed equivalent health for no intervention and for e-cigarette. So the results show here, the e-cigarette, the EDE for e-cigarette are higher than the EDE for no intervention. So the change is positive. We observe a positive change in EDE health. However, the EDE is calculated based on the population health and the distribution. So if there is an increase in EDE, it can be because of an increase in overall health or reduction in health inequality or both. So just based on this change, it's hard to conclude whether the inequality increased or reduced. So here we use another, we need to do some more calculation. We know the population size as previous steps, and we can calculate the Atkinson index, Atkinson EDE for no intervention, the Atkinson EDE for e-cigarette. Based on this, we can calculate the population level incremental EDE, the difference of those two multiplied by the total population size, which equals to like 70,000 QALYs. And we also estimated the incremental net health benefit from previous steps. So here we can calculate the population incremental net health benefit, just the sum of those 5 numbers. So we have the population level incremental EDE and the population level incremental net health benefit. We take the difference. So the difference is about minus 11,000 QALYs. So this will be our measure for the inequality impact. So the next step, we can plot those results in this equity impact plane. So the y-axis is the impact on overall health. It's the population level incremental net health benefit. So the value is about 81,000 QALYs. The x-axis is the impact on health inequality, the difference between the incremental EDE and the incremental net health benefit. It's about minus 11,000 QALYs. Based on those two values, we can plot the results here. It's on the top left quadrant. So if the intervention in this quadrant, it means it is estimated to increase population health and increase health inequality. So then if decision maker want to fund this particular intervention, some trade-offs may be made, because it's good for the population health, it improves population health, but it will harm health equity, because the worse off people, they benefit less from interventions than the better off people. And that's almost for the results we get for this example. So yes, so the next is if you would like to know more examples about the DCEA applications, we have more examples, more published papers at this website. Yeah. Hi,
okay. So there was a couple of questions in that. One was asking how to explain how we estimated the distribution of health opportunity cost across subgroups. And so Fan explained how the costs in different groups are estimated, and we can total them up and translate them into health opportunity cost. The way that we have measured the distribution of the health opportunity cost is by taking the same approach as a study that estimated the marginal productivity of health spending in the UK. So that looked at when you change budgets in spending areas of healthcare, PCTs within the UK, what was the impact on health outcomes? And they measured that in terms of quality adjusted life expectancy. They estimated that. So for a change in spend at the margin, they estimated the change in qualities that you would get. What we did was extend their analysis to say, when you change healthcare spending, what disease areas are affected. That's what they did. But we also looked at the characteristics of people that were using those interventions in each of those disease areas. So extended it from looking at just the distribution by disease area and converting that into quality adjusted life expectancy to looking at the change in spending as it fell to different groups within the population. So if you have a study looking at the marginal productivity of healthcare spending in your setting, you could simply extend it in a similar way to try and add in your equity characteristic to see if it affects what's the marginal benefit to different groups within that. And then there was another question as well about whether you can get counterintuitive findings if the incremental net health benefit gains are driven by cost savings as opposed to quality gains to that population segment. So I mean, this might be similar in notion to something that is less effective but less costly. In a standard cost effectiveness health maximization framework, your positive net health benefit or your incremental cost effectiveness ratio comparing favorably to your threshold would be driven by cost savings in that sense and the health gains that those cost savings enable, rather than the health benefits to the population group. So I don't know if it would be considered counterintuitive, but in the example of smoking cessation, pretty much it's cost saving for the health service. So you wouldn't. So on that basis alone, it should reduce health inequalities because it's reducing NHS costs and allowing them to be used for other services which we know benefit disadvantaged groups more. But what we see is the uptake at present is such that that kind of outweighs that. So it still has a slight increase in inequality. Smoking cessation is extraordinarily sensitive in terms of its inequality impact into how well you target it and how well you address the differences in uptake.
Can I follow up?
Yeah.
So, but like hypothetically, with this framework, if there were an intervention that, like, in an extreme crazy example, like killed old sick people in the lowest quartile and saved a lot of spending, would that show up in the distribution of the incremental net health benefit as somehow increasing net health benefit because it's getting both costs to the system and qualities to the group? Like, is there theoretically that could make it look like the net health benefit is actually increasing because of the effects of the intervention in that group that's actually killing them, thus totally counterintuitive to what we're trying to do with incorporating equity?
Well, I mean, so it would again present the same problem with standard cost effectiveness analysis. On average, that group would experience a gain in population health, but for the individuals receiving that intervention, they would not. That's a I guess a conceptual possibility with standard cost effectiveness analysis potentially killing off expensive people versus this type of approach. Now, in this approach, by presenting kind of the baseline distribution and how it changes the baseline distribution, you can answer some questions, provide useful information on whether you might be leveling up as opposed to leveling down. So there's a concern with health inequality analysis, not that you might be killing off costly disadvantaged groups, but that actually you might be improving health inequalities by leveling down, by curtailing the upper groups. And generally that's not the case in the ones that we've looked at. So generally most people are gaining. But the issue with the opportunity cost and this concern with inequalities, it is a redistribution. So you're not harming health, but the program that you maybe would favor on a population health and health inequality grounds is not going to increase the most advantaged group's health by as much as alternatives. So you're not, killing them and you're not taking away any health that they've enjoyed, but you're allocating your resources differently, so they stand to gain less than they would have done if you ignored health inequality impacts. This is the consequence of not always choosing, for example, the health maximization one. You get less future population health potentially because you value that being more equally distributed.
I guess I'll put it one more way and then I'll stop.
Okay.
Which is why net health benefit distributed across the groups as opposed to just qualities distributed across the groups? Like, don't we care about the health distribution, literally health, the qualities, the actual qualities, as opposed to the system level health spending, which might not necessarily be redistributed in an equal way? I'll stop and listen.
Okay, so I mean, the way that we conceive of that in our analyses is those opportunity costs are health benefits, so we wouldn't necessarily distinguish them. So you could focus just on the qualities. I mean, we're doing this within the context of our usual application of these things within the NHS. All of the NHS money is being spent regardless, and we're changing how it's spent, so we're within that kind of level of thing. But you could present just the distribution of qualities on its own if you didn't think perhaps those costs translated into health impacts. But we've translated those costs into health impacts, and that's why we're looking at them in addition to the distribution of qualities.
I have another question. So you using those 20,000 pounds per quality health opportunity cost threshold across the 5 different quintiles. And do you think, I'd like to hear your thoughts on applying the different health opportunity cost threshold across different groups, because our health opportunity costs may obviously differ by these groups. And the way I'm thinking about when I applying to the US setting, which do not have explicit health opportunity cost threshold, then people may want to use more willingness to pay demand side approach. And in that cases, if you're doing like this distributed cost effective analysis, what's your thoughts on applying different thresholds for the different population? If, for example, like income group, income quintile, their willingness to pay thresholds for these income quintiles very different. So I'd like to hear your thoughts.
So you can, in many cases, show the equivalence between different approaches to this. So if you were thinking about applying a different threshold, that is actually compatible or a kind of rearranged equation of the way that we might be doing it with an Atkinson index. So translating it just into health foregone and then applying a weighting factor at that point in terms of the distribution of health. So we can actually calculate from our approach, we could calculate an overall threshold in terms of equally distributed equivalent health, and we can do other things like that. We could show kind of the differences across the groups. So you can approach this in different ways, and you can show the equivalence between these things. The difference, as I mentioned earlier, with if you are using something like an Atkinson index, is that those weights are not going to be steady. If you're taking a different willingness to pay for different population groups, that's more like an explicit equity weight, I guess, that you would be applying to those groups. So you could take it that approach. So I think people have looked at this before when they're looking at weighting qualies. Do you put the weight on the quali that you're calculating, or do you leave it to put it in the threshold? And so those should in principle be two sides of the same coin, but it can lead to slightly different things. The challenge that we faced with converting, in the case that we did for looking at the stuff that done by the National Institute for Health and Care Excellence, is that the that threshold, that priority you give to them, is a function of their baseline health and the level of inequality. So as population health improves over time, that alters. Which, I mean, that's arguably an issue with cost and effectiveness thresholds anyway, that as income and health is improving over time, you might want to continually update these things. But that's also a case there that that would alter. Whereas if you've measured the extent of inequality aversion, it will naturally update if you're applying it at the outcome side of things. Yeah, but I think that this approach here, one benefit of doing that is it definitely makes sure you've taken into account what the opportunity cost looks like, where that's falling. So the danger with the threshold, with the standard cost effectiveness threshold, is you're ignoring who is foregoing benefits. With a willingness to pay approach, it's a bit more complicated. So the kind of inequality aversion we're typically focusing on is a societal level preference for reducing inequalities in health. It doesn't necessarily, you can measure people's individual kind of altruism or aversion to health inequalities, but it is a kind of societal level valuation of equality in health that doesn't necessarily translate so easily to willingness to pay, especially if you're looking at willingness to pay in terms of individuals and the utility they gain from alternative uses of their income. Okay, so we've run a bit over time on our break, but we'd still like to give you a break of at least 15 minutes, I think. But if should we come back at 10 past the hour? Does that make sense to everyone? So if we take a nice a break now, come back at 10 past the hour and start talking about the exercise. And thank you so far. Please put any more questions. Oh, I see I've got another one from Heather here. So, this is about the deprivation indices and national versus localized decisions. I mean, this basically, I guess you tailor it to your decision maker, the context in which you're informing it. So we've done some work that looks at it nationally. We've also done some work that looked at local areas. For example, looked at a low emission zone in West Yorkshire, and West Yorkshire, the area that we were looking at, was a very deprived area. So relative to the rest of the UK, it's very deprived. But when you're looking at redistribution within that area, everyone's within that area is in a more similar situation compared to relative to the rest of the UK. So it kind of depends on the scope of that. And we had some questions to address there in terms of where the opportunity costs fall. Do the opportunity costs stay within the area, or so within the NHS spending bodies within that area, or are they spread across the country? So you have to take into account those issues, like where does these opportunity costs fall? Okay, so I'll see you all back here at 10 past after a bit of a break. Right, hello everyone, welcome back. Hope you enjoyed getting a chance to stretch your legs and take a break from Zoom and from looking at the computer screen. What I'm going to do with the exercise is I'm going to kind of walk through it, really kind of, I guess, talking about some of the concepts that we've thought about so far and talking about some of the learning aims with it. The way that we designed this exercise was with quite step-by-step instructions to allow you to have a play around with it yourself. So it's designed so that when you change numbers within it, you should be able to see visually how that impacts the type of conclusions that you get. I'm going to share my screen now. I've done a bit of practicing without sharing at zooming in a bit on this, but I know that sharing Excel spreadsheets often doesn't come across in the clearest way. So bear with me if it does not come across, and feel free to just indicate if there is a problem with being able to see it properly. So, okay, can everybody see that on the screen now, that that practical? So, if I can adjust things on here. So you've been provided with a student file and a solution file and a series of step-by-step instructions. And the exercise is split over a number of sheets here. It's a hypothetical situation. It should show you some of the calculations of some of the Atkinson index that we've been talking about, and it also provides a bit of information about the weights and stuff. This exercise was developed with some colleagues here. Mick Dadazaria and Andrew Mirrellman helped to develop this exercise as well. So if you go through the exercise instructions, it will take you through the different sheets, and there are square cells highlighted in green that are for you to fill out based on the information that is provided within the spreadsheet. So you don't need anything other than the step-by-step instructions to complete all of these sheets. If you have any problems, you also have the solution file, which is already completed for you, so you can compare against the results within that file. And as I said, once you've completed it, feel free to play around with it a bit and change some of the numbers and see what happens. So the hypothetical example we're presenting here is between continuing to invest in program A or ceasing to invest in program A and reinvesting the funds in program B. Program B, you can see here the incremental individual health impact from program B in terms of quality adjusted life expectancy. That's in column C of sheet 2, the health impact. And you see that for program B, the poorest 2 groups gain in terms of health, and the richest 2 groups lose out in terms of health. Now we're talking net health benefit here again. An example of a program like this might be, for example, should we invest in a program that's targeted particularly at these 2 groups? So you would only see health benefits in those groups, and you would only see opportunity costs falling in the other 2 groups. So it's potentially an example of that type of policy. So it's not necessarily that we're harming the health in the richest groups, but in terms of the incremental change from what they got under program A, they're expecting to achieve less health because of these opportunity costs. Now, of course, as Fan showed in the calculation process, in the models that you develop, you will have information on the QALYs, the direct QALYs gained, if you've adapted your cost effectiveness model in each of these groups, and on the opportunity cost. So you could look at those 2 things separately and see what's causing this. In terms of these histograms that we've provided here, these plot the health impact under program A and program B in the blue and in the red. And then we've got this incremental population health impact of program B on the bottom here. So if you do want to provide information on the health benefits derived from program B and the opportunity cost, you could plot separate bars on this and then add them together if you wanted to display that information. In practice, in many of your models, if you adapt them in this way to perform distributional cost effectiveness analysis, what you may find is that the actual scale of the impacts is quite small. We've got a per person impact here, an average individual health under each program. And you can see we've got quite a big change in our hypothetical scenario here. But the per individual change in health in your population group might be very, very small. One thing to bear in mind in that is the scope of the analysis, the population that you're considering. We're often widening it from the people who receive the intervention to include everybody who could benefit from anything that could be funded from the same source. So if we evaluate smoking cessation, then we are looking, we're moving from looking at the benefit within smokers to looking at the benefit across the whole of the population, including non-smokers as well. And that just scales down the size of the benefits. What that means is visually, you don't get nice big changes in your histograms like this. So the measures, all the things apply, but actually the numerical change in your slope index of inequality, in your individual quality adjusted life expectancy is going to be on a small scale. That doesn't mean it's not valuable. And when we add it up to population level, we can see some quite large impacts. But just to note that this hypothetical example here is scaled large for you to look at it. So you can look at the life expectancy, quality adjusted life expectancy on program A and on program B, in terms of this graph, and then you can multiply it by the population size. So we've got 5 equally sized groups, so quintiles here. In terms of how you want to split your population, that depends on your equity characteristics. So when we're using indices of multiple deprivation or measures of socioeconomic advantage, we often just do it into equally sized groups. If you're looking at particular ethnic groups, you might have groups of quite different size as well to take into account. So once you've completed that, this is the information that you would get if you had adapted your cost effectiveness analysis to basically provide you the incremental costs, the incremental QALYs, and the incremental net health benefit in each different subgroup. So as I say, we've done this mainly by doing subgroup analysis of our cost effectiveness analysis. We took the standard NICE model for smoking cessation and expanded that to look at different subgroups, or we started directly. So for air pollution from the get-go, we built the model looking at different groups by different IMD, but we've also worked with Colin Angus and Duncan Gillespie at Sheffield to adapt an individual based model looking at alcohol policy, so brief interventions against alcohol. So this approach of estimating the incremental effects in different subgroups applies across a range of different modeling approaches to cost effectiveness analysis, and you'll end up with something like this by one means or another, which you could enter into this. So that's just sheet number 2 and lets you visualize some of those things. So in terms of the equity impact, what we would advise is once you've done that first step, so sheet 2, the health impact, if you were in the win-win situation or the lose-lose situation, you don't need to worry about the trade-off, and you don't necessarily need to worry too much. If all of your inequality measures agree, you don't need to worry too much about which one you're looking at, because you don't have a particular concern. It's in that trade-off situation where you need to start worrying a bit more about calculating these more complicated measures, or using weighted QALYs, or using some kind of weighted thresholds. This exercise here on sheet 3 contains the formula to calculate the Atkinson index as a function of this inequality aversion parameter E. So it's a bit of a nasty formula, but within a spreadsheet, it's pretty easy to calculate. Using the information, you could also calculate a Gini coefficient or similar things like that. So you can summarize these things. So what you'll have is a few stages of calculation for the Atkinson index within this spreadsheet. So it looks a bit nasty to look at. But overall, you end up with the equally distributed equivalent, which you can compare to the average population health. So in program A, we have an average population health here of 74.1 years. Program B, we have an average population health of 73.7 years. So this is an unweighted look at the total population health, just simply summing across all of the individuals in the population, calculating the average health. Then we've used our formula and our inequality aversion to calculate the equally distributed equivalent health here. And you can look at the formula underlying this if you want. It references to a named cell within the sheet called initial E, which you can adjust, so you can change the level of inequality aversion. So if you haven't used Excel before, this part of the formula here, D15, is a cell reference. So it tells Excel the number within which cell it's using the calculation for, but you can also name cells, and it will Excel knows where initial E is. If you want to know where that is, you can drop down this menu here in this cell box and just click on it, and it will drop you right to where that named cell reference is if you want to have a play around with that within this exercise. But if you're familiar with relative cell referencing and absolute cells names and referencing within Excel, you should be able to navigate this spreadsheet relatively easily. But what you'll see here, that it asks you as part of the exercise to kind of make use of that function. So if you're not comfortable doing that, do feel free to skip straight to the solution file. And for program A, it calculates an equally distributed equivalent health of 71.5 quality adjusted life years. What that implies is that compared to this distribution of health that we see under program A, where the poorest group expect to see 65 years in full health, the richest 81 years in full health, given the level of inequality aversion, we'd be equally happy with a program that ensured that everybody had 71.5 years life expectancy. That's the description of the trade-off that's embodied in that inequality aversion value E, which I think in the first instance here is quite high. Let's just go back to initial E. So that's a value of 11. That corresponds to a UK population survey that asked people to trade off between programs that improved the health of rich and poor people differentially and changed the level of inequality aversion. So one thing to mention here with this Atkinson E parameter, it's quite tricky to measure. So we encourage a lot of sensitivity analysis around that. It's part of this exercise to look at how sensitive the results are to different values of that inequality aversion. It's very sensitive to how you frame the question, and you have to do a lot of training, and you can get a lot of different answers. There's quite a lot of research in this area now. And as I mentioned before, if you ask people about aversion to inequality between rich and poor groups, you get a much higher number, a much higher level of concern compared to if you ask for inequality aversion between people who are less healthy versus more healthy. So we see that because program A is unequally distributed, the health, then it has an EDE lower than its population health level. So that's how we can tell there's inequality there. If it was perfectly distributed, equally distributed, these two numbers would be the same. And we can see here with program B the same numbers. So with program B, as you saw on the previous slide, you get less health overall. It's not cost effective. It improves health in the worst off groups, but it doesn't in the richest groups. It wouldn't be regarded as cost effective, and it reduces population health overall. But when we calculate the equally distributed equivalent, what we see is it's actually higher with program B than it is under program A. The equally distributed equivalent is taking account of the fact that our welfare is reduced by having less population health. So it does account for the loss of health between program A and program B, but it's also being improved by the reduction in inequality because there's a lower gap between the groups in program B. And the balance of those two factors, so reducing your population health, if nothing else changed, would reduce your EDE, and reducing your inequality would increase your EDE. The balance of those two factors plays out that program B is actually looking to be equity improving in this exercise, and you can play around with the numbers to adjust that. So that's the equally distributed equivalent. This here is the Atkinson index itself. So it's part of the same metric. It depends on this Atkinson E. That's the percentage of welfare loss that is from the level of inequality in the distribution. So if it was perfectly equally distributed, we'd have a 0 because there would be no inequality, no welfare loss from the presence of inequality in our distribution. Similarly, if we were not concerned about health inequality, if we had no health inequality inversion, again, there would be no welfare loss from this. But if we were only concerned about inequality, then any program that had any level of inequality, we wouldn't want it. So we'd lose all of our welfare. It would be 100% of the welfare would be lost by the presence of any inequality. So that Atkinson E determines this percentage here, but there's not a neat translation between the particular number, in this case 11, and how it impacts on the percentage of social welfare, because it's very dependent on the starting distribution. So if you go to this slide and alter these numbers, you will also see a change in the answers, as well as if you alter these numbers about the incremental effect of the program. So you'll change the overall conclusions by changing your baseline distribution, as well as if you change the incremental impact of your program. But once you've calculated where program B lies, this will plot it for you on a health equity impact plane. So if you remember, we've got the cost effectiveness, the net health benefit on the y-axis, and program B is not cost effective. And we've got the inequality impact. This time it's measured by the Atkinson index on the x-axis, and it's reducing inequality. So just a quick reminder, if you hadn't spotted it before, we kind of put the negative here of the intervention because we're interested in positive effects moving to the right and negative effects moving to the left. So we flip the measure. So the greater amount of inequality you have, we want you to be moving to the left. So in terms of the depiction of the plane, we've just taken the negative of the extent of inequality there, if that makes sense. But if you adjust the figures in the example, this dot will move around and you'll be able to see what impact that has. We're in one of the trade-off quadrants, so less inequality but less health. And this sheet here allows you to look at the trade-off. So as I said before, down here we've got a range of values for inequality aversion, and this first column is completed for you in the exercise. And it just allows you to calculate the equally distributed equivalent under both programs for different values of this inequality aversion parameter. So I think I mentioned earlier that this was originally developed to focus on income inequality. And actually there was remarkably little attempt to measure the extent of income inequality aversion. And it became kind of standard practice to apply values of 2 or a half. Those were pretty standard values to use in that. But there wasn't much extent of determining what's the level of inequality aversion. There's been more in the context of health inequality, but as I said, it's a tricky thing to measure. Some studies have reported values as high as 26, and some have reported values that are very low. And some studies that look at the difference between, that look at pure health inequality aversion are much more down this end of the scale, kind of a half or 1 or even 2. and the ones that look at the relation to income or poorness or socioeconomic disadvantage are higher, so in the region 5 to 10 or something. But this is a very contentious number, and it's something where you would want to do sensitivity analysis or even threshold analysis, we would suggest, within your model. If you're in the trade-off quadrant and you want to provide information about how inequality averse do you need to be to prefer program B over program A. And that's what this graph is doing. It's plotting the change in equally distributed equivalent qualities between program B and program A. And we can see that at low levels of inequality aversion, if you don't care at all about inequality aversion, you just want the health maximizing program, or if you're not particularly concerned about health inequality aversion here, you'd still want program A, because you value the increased health gains more than the increased then you lose out from the increased inequality. But at this point here is a threshold where you'd switch this level of inequality aversion, you'd switch from preferring program A to program B. So this threshold can be useful information to provide, because if your study says it's about 11, but you know it's uncertain, it's difficult to measure, you can tell the decision maker this threshold, and then they can take into account, well, there's a variation of possible values this E could have, but consistent with all of them, it seems like program B looks like the optimal choice. So that calculates ED for different values of inequality aversion. And then this final sheet is the one that you might want to focus on to play around with once you're familiar with all the different sheets and what the exercise is doing. Because when you make changes, it should immediately reflect in the diagram. So if I change that inequality aversion parameter from 11 to 2, you can see that the movement on the dot on the health equity impact plane. So you get to see immediately what the changes that you make do. And that should work for all of these things that you can play around with. Now, what Miqdad did when he was developing this was to provide a way to translate this Atkinson E into a kind of weight that's applied to the poorest fifth. So as I mentioned before, you can calculate an implied weight that you are giving to different groups from a particular value of this inequality aversion parameter. So if you use 11, which is the starting point, this is the implied equity weight that you're giving to the poorest fifth. So you're valuing a QALY 11 times greater if it's going to the poorest fifth of the population than you would if it went to the richest group. So this is quite an extreme inequality aversion to get a value of 11. And this here is the percentage of the proportion of total health that you're willing to sacrifice for equal health in this particular example. But you can change this number if you want, and then click this button, and it's got a macro. So when you open this Excel spreadsheet, please do click enable macros if you want to enable this facility within the exercise. And what it will do is it will recalculate the implied equity weight given to the poorest fifth. It's not a straightforward thing, and Miqdad did a workaround to get it to compute that here. And so you get to see all the different graphs that you might be presenting here. We didn't do one separately with QALYs and opportunity cost, partly because this is hypothetical and we didn't calculate any of those things. This is the kind of sheets that you can ignore. So these later ones are the kind of working parts underneath some of those calculations. So they're there if you're interested in having a look at them, some extra sheets here, but they're not part of the exercise. It's mainly 1 to 5 that goes with those diagrams. So that was a quick walk through what the exercise is and some of the things to bear in mind. Does anyone have any questions about the Excel spreadsheet that I could address while I have it open? Okay. Well, we hopefully designed the exercise with quite step-by-step instructions. So if you want to have a play around, hopefully it's quite self-explanatory. But I think, oh, there are some questions in the chat. I can't see the chat when I'm when I'm sharing the file. So I can take a look at that, Heather, to see what's the issue is. Oh, it's the format of the cell. So one question that's come up is talking about using the term equity and equality, and that we have been changing between them, and that's a bad habit on my part to exchange because they're not equivalent. The method that we are talking about here primarily measures inequality and focuses on inequality. And that is not the same as inequity or equity. Equity requires a value judgment about whether that's fair or unfair. So it's not just the extent of inequality. That's why it's important to be very careful about reflecting your stakeholders' concerns, who you're aiming to inform, being very clear about what inequality you're measuring and the kind of weights that you're applying to that. As to whether or not that reflects their equity concern. But the method here and the numbers we're calculating and the slope index of inequality and all of those kind of things, they merely measure differences between groups. They're just looking at inequality. I don't know if there's any other questions from earlier that we maybe haven't addressed yet. Does anyone have any other questions about this? I mean, in terms of some practical things about adapting models for inequality impact, obviously it's more data hungry than if you're just performing a standard cost effectiveness analysis. So you're searching for evidence on how things within your model vary according to the characteristics that you want to capture with your equity concern. We've managed to find good information in some areas and less information in others, but I think this is probably going to be like a demand driven type thing where people will start producing more information in relation to these things the more it actually gets used. So if the National Institute for Health and Care Excellence made this a routine part of their public health guidelines, and then routine administrative data might be examined more in these terms as well, and all of these things might come together. So there's a question about whether the Sheffield one is published. Fan, is that out now, the impacts with the alcohol model? That is, isn't it? Is that?
Yes, yes.
So
I can send that in the chat box.
So with the Sheffield alcohol model, that was an example of a simulation model where they had already taken, it already integrated socioeconomic characteristics and looked at differences between groups. So to extend that to a distributional cost effectiveness analysis was reasonably straightforward. So we needed to bring in the health opportunity cost part of it and look at a couple of other adaptations that they hadn't looked at that point. But some simulation models will be very easy to adapt to this method here.
Hi, Susan, we have a question here saying the book promotion code is not working.
Oh, okay. Okay.
We may need to update that.
Yes, I'll have a look at that. I think I've got everyone's email address. I can see why that is the case and see if I can fix that and send that around. I'll dig through my emails. But yeah, so in terms of the inequality aversion parameter that we used one from a survey in England. There's been a couple of surveys in England actually of this, but there are surveys in other settings that have looked at these parameters. So you can get health inequality aversion in other settings in terms of this Atkinson E. There's Arthur Atima has done a bit of work in this, looking at inequality aversion. and off the top of my head, I can't think of all the different studies, but that there is things in this area. And also we're using Atkinson, the Atkinson index, and that's got that particular inequality aversion parameter. But of course, there's a number of different ways you can specify a social welfare index and incorporate factors related to inequality aversion. So Paul Dolman and Aki Sutia, who've done some work in this area, specifying particular social welfare functions and looking at levels of inequality aversion. So you don't just have to use an Atkinson. In fact, what I didn't say was that Atkinson index is a measure of relative inequality. So we've also looked at the Colm index, and that's got an alpha instead of an E, but again, it's a parameter that describes the extent of inequality aversion. So you can look at different measures. So E can be estimated using conjoint analysis. Yes, a discrete choice experiment. That's pretty much the way that people have gone about estimating it in the way that we've looked at it so far. It's also something that in principle might be revealed. You might be able to estimate an implied inequality aversion if you look at the extent of redistribution or that healthcare resources achieves. That's quite tricky. That's something that's more straightforward within the income application. People look at kind of the optimal tax, trying to back calculate from the progressiveness of the tax situation that's in place, how income inequality averse people are. Doesn't quite work with health. I mean, it's not, because you're not transferring health between people in the same way, and it's much more tricky to measure. So just conjoint analysis is much more straightforward for measuring stated preferences, but revealed preferences are in principle something you could also look at as well. Okay. Well, I hope you've all enjoyed the course, and I'll see if I can sort out that code if it's not working, and see if I can get it fixed. If anyone does have any further questions or any problems with any of the exercises, do feel free to drop Fan or I an email, and we can see if we can help you with them, and enjoy the rest of your day and the rest of the conference for this Tuesday anyway. So okay, I'll let you all go now. Another bonus screen break.
Thank you.
Okay. Right then, bye everyone. Thanks for joining.
Thank you for very much. Thank you.
Great. Thank you so much. Bye-bye.
Thanks. Bye. Okay, thanks everyone. I'm going to sign off myself now. So bye.